When an infected Anopheles mosquito pierces human skin, it transfers the Plasmodium parasite directly into the bloodstream. It is a highly efficient, highly localized biological transmission. Countering this transmission is the primary objective of India's National Vector-Borne Disease Control Program. The state has committed to the World Health Organization's E2030 target, the total elimination of all indigenous malaria cases by the year 2030. This mandate requires a logistical optimization across a massive geographic footprint. In high-burden regions like Odisha and Chhattisgarh, remote tribal populations and dense variable forest cover create a major structural bottleneck for intervention. This historical photograph shows how vector control was largely handled in the past. Agencies relied on blanket interventions, fogging entire areas with DDT, or widespread indoor spraying to suppress mosquito populations. These analog blanket interventions are economically inefficient and ecologically taxing. More importantly, they frequently miss the tiny microhabitats acting as true reservoirs for mosquito reproduction. Achieving elimination requires shifting from these blunt force tools to a multi-layered, data-efficient artificial intelligence ecosystem. Eliminating malaria at a subcontinental scale has evolved into a massive logistical and data deployment challenge. The first layer of this ecosystem is larval source management, or LSM. This proactive strategy targets the immature aquatic stages of the vector, the larvae, before they emerge as biting adults. LSM requires high-precision spatial data. Most breeding sites are smaller than 1 meter, making them effectively invisible to coarse, free satellite telemetry like Sentinel or Landsat. These drone collection sites in West Africa demonstrate the hardware solution. Autonomous drones capture high-resolution multispectral imagery across variable terrains, picking up topographical dips and shaded standing water that humans cannot spot on foot. To process these millions of images, researchers deploy software layers based on UNet and attention UNet convolutional neural network architectures. This validation interface shows how the network analyzes pixel patches, comparing manually labeled ground truth masks against AI predictions to segment land cover types. The model consistently identifies potential habitats, achieving a DICE coefficient of 0.88 for tillage and 0.75 for non-vegetated water bodies. This flowchart illustrates spatial data integrating into an operational workflow. The system uses human-in-the-loop processing to refine the AI's training engine. Topographical neural networks convert complex visual data into precise GPS coordinates, allowing ground teams to navigate directly to automated targets. In field trials, AI-guided larviciding reduced localized mosquito populations by over 60% in as little as 3.5 months. Precision targeting drops intervention costs to roughly 20 cents per person protected. When compared to the $5 cost of blanket house spraying, the economic superiority of precision spatial AI becomes a mathematical certainty. While spatial AI handles environmental vectors, the next layer must manage point-of-care patient diagnostics. At the clinical level, the primary diagnostic tool is the Malaria Rapid Diagnostic Test, or MRDT. However, these tests suffer from high rates of administration and human interpretation errors in the field. Deployment in rural settings is further constrained by a lack of specialized medical training for community volunteers and unreliable internet connectivity. The Health Pulse app standardizes workflow on a smartphone, enforcing a 15-minute countdown, photo capture, and local image validation. Field data confirms success. 89.2% of tests were processed within required time bounds, and 91.4% of photos passed the AI quality check on the first attempt. Edge-based machine vision enables the digitization of unstructured field data, allowing health systems to capture human protocol breaches in real time. In 3.5% of encounters, the AI flagged instances where health workers dispensed artemisinin-based combination therapy, despite the algorithm reading a negative RDT result. Digitizing this feedback loop transforms a clinical blind spot into actionable telemetry, allowing supervisors to provide targeted guidance exactly where protocol failures occur. To manage malaria at a national scale, public health systems must migrate from reactive data collection to predictive surveillance. Forecasting an outbreak requires processing complex, unstructured data streams, sea surface temperatures, localized climate patterns, patterns of human mobility, and historical case records. Long short-term memory, or LSTM, networks are uniquely suited for this task. These neural architectures process time series data to identify subtle environmental shifts preceding a surge. These models can predict outbreak probabilities up to 9 months in advance with roughly 80% accuracy. This predictive capacity is critical for India's transmission topology, where monsoons and temperature shifts create highly seasonal and localized risks. Integrating LSTM pipelines into the Integrated Disease Surveillance Program transforms resource allocation. It allows the state to proactively deploy medical personnel and nets before a predicted outbreak peaks. The final layer of the architecture operates at the micro level, molecular therapeutic design. Historically, vaccine development was stalled by complex protein structures. These are the structures the malaria parasite uses to infect human cells. Google DeepMind's AlphaFold has resolved this bottleneck by predicting the specific structure of PFS 4845, a critical protein target that had eluded biochemists for years. By combining physical cryo-EM data with AlphaFold's AI-generated structures, researchers can now map the entire protein complex with unprecedented speed. Molecular AI bypasses years of structural guesswork, rapidly accelerating vaccine candidates into clinical development phases. Successfully eliminating a disease at a subcontinental scale requires treating the effort as a unified data engineering problem. The stack begins with spatial CNNs providing precision for larval management. The clinical layer follows, where edge vision secures diagnostic fidelity in remote districts. Finally, systemic layers bind the ecosystem. LSTM forecasting and AlphaFold mapping provide the macro strategy and tools to finish the job. Standalone pilot programs are no longer enough. Achieving the E2030 mandate requires full interoperability across these systems to move India toward a robust, unified digital healthcare infrastructure. For technical professionals, the objective is now a matter of scale. India's elimination goal depends on transitioning these specific AI architectures from the localized trials into permanent national digital public goods.